All right, let's get started. For people in the back, there are plenty of seats up front where you don't have to sit right next to somebody if we're going to practice some social distancing, which apparently two people listened in the whole audience. So these are things you're going to have to start getting used to in the coming months. So if I yelled at you, would you do it? Or if the public health authority said to do it, would you do it? So think about those things. If I started coughing and walking around the auditorium, would you move away from me? So I think just be mindful of the world we're going to be living in for the next 6 to 8 weeks probably. So welcome to a panel put together by the Dornsife School of Public Health. My name is Mike Udell, and I am professor and chair of the Department of Community Health and Prevention here at Dornsife. We are here for serious reasons today. We have an amazing panel of experts that we will get to in a few minutes, but I wanted to share a few opening comments to contextualize the public health challenges and needed responses that lay ahead. A few reminders as we begin. The first thing to state is that we should all be following the guidelines issued by state and local public health agencies whose job it is to protect us. Those basic guidelines for now include washing your hands regularly for 20 seconds, avoid touching your face, stop shaking hands and hugging, get a flu shot if you have not. We're at the tail end of flu season, but should you come down with the flu and end up in a system that is potentially going to be burdened by COVID-19, that would not be a great thing. Stay home if you're sick and call a doctor if you have a fever and cough, and practice social distancing when appropriate, including please do not get on a cruise ship right now, especially if you're in a high-risk category. Also, very important, remember that in times like these, people can face significant stigma and discrimination because of the groups they belong to and the associations they may have to the disease. Let's make sure that we are better than singling out groups in the wake of this mess. Now, the events that are unfolding around us are intimidating and can be confusing, but remember that the vast majority of people will not get sick from this, and that only a small minority of patients who do get sick are at high risk for complications, including death. Now, despite the insanity of this moment, I am heartened that the response by most people on this planet, with some major exceptions, has been to roll out an intensive public health response so that we can save the lives of the most vulnerable, older people, people with chronic health conditions, and healthcare workers who will be on the front lines of this. Even though we may face significant inconvenience and economic and social impacts because of that inconvenience. Remember that the steps that are being taken by public health entities, businesses, universities, and schools are to do just this, and that should give us hope even in these crazy times. Now, as a historian and ethicist of public health, I want to give a few brief reminders of Philadelphia's history with epidemics, which is not a pretty picture. In 1793, a yellow fever epidemic took approximately 5,000 lives here. The city's population at the time was over 50,000, but more than half the city fled to the countryside, which was then Germantown and out in Jersey. But a lot of people died. People didn't know what caused the fever, although there were lots of different ideas for that. But at the end of the day, when the fever subsided, what would later become the Philadelphia Public Health Department came into being, and the city developed the first municipal water supply in the country, so there were real improvements and some hope that came out of that. More than a century later, in 1918, Philadelphia was devastated by the influenza pandemic of 1918-1919, which killed more than 12,000 people in the city and sickened about 50,000. It was the highest death toll for any city in the United States. What drove this high number were bad decisions on the part of city leaders, including the city's health director, Wilmer Cruson, who greenlit the Liberty Loan Parade, which drew more than 200,000 people to Broad Street on September 28th. And he underplayed the danger, calling the outbreak nothing more than an old-fashioned influenza. Within days of the parade, Philadelphians grew sick, and within 3 days following the parade, all beds in all of the city's 31 hospitals were in use. And on October 3rd, the city issued an order closing all schools, churches, and places of amusement. Now, for those of you who have not been on the news in the last hour, just a few minutes ago, the mayor and the health commissioner announced the first case of COVID-19 in Philadelphia. And the health commissioner issued a warning urging all of us not to attend gatherings of 5,000 or more people. That is probably not enough, and my suspicion is that that will change rather quickly. Social distancing measures that we will discuss today can be an effective tool in reducing the spread of this disease. And on today's panel, which I have the pleasure to introduce, you will find out why this is the case. So we are joined by 4 incredible faculty from the School of Public Health: Mike Levasseur, Esther Cernik, Joe Amon, and Jim Bueller. I will let them tell you a little more about themselves as they come up here and share with you each of their expertise on the outbreak that we are now facing. Thank you, and I hope you really enjoy this panel. It's really important. Esther.
Good afternoon. My name is Esther Cernik. I'm a faculty member in the Department of Environmental and Occupational Health, and my background is I'm an infectious disease physician. We actually exist. It's a subspecialty. We come in handy at times like this. And I spent much of my career in public health and in clinical medicine taking care of people with infectious diseases. My task for today is to set the stage, and I'll talk a bit about coronavirus 19 and its clinical manifestations. I'll talk a bit about the diagnosis and transmission characteristics, and I'll talk a bit about treatment and prevention so that we can have a good discussion in the next 90 minutes. So coronavirus, COVID-19 is the name of the disease that is now this global pandemic. It is caused by SARS-CoV-2, SARS coronavirus 2, and it is a member of the coronavirus family, which includes a number of human coronaviruses that are quite common in human disease and cause common colds. But in the last 20 years, there have been 3 animal-associated coronaviruses that have successfully jumped the species barrier to cause human illness. In 2003, we had SARS-CoV-1 cause the SARS outbreak of 2003 that began in China and then spread throughout the world, including parts of Asia as well as Canada. In 2012, we had the MERS coronavirus, the Middle Eastern Respiratory Syndrome virus that arose in Saudi Arabia. In December of 2019, we had SARS-CoV-2 emerge and cause a cluster of human infections in the city of Wuhan in China, and then eventually spread throughout China, much of Asia, and now throughout the world. All of these 3 animal-associated coronaviruses are beta coronaviruses that probably originate in bats and successfully navigate their way to human beings via an intermediate host. In 2003, we believe that intermediate host was the civet or civet cat. In 2012, the MERS coronavirus probably infected humans via camel-associated contact. And we're not 100% sure about where this current coronavirus infected humans from. It may be an animal called the pangolin, but we're still not sure, but they're all basically bat-associated coronaviruses. Of all the 3 that have successfully navigated and jumped the species barrier, this particular coronavirus has adapted to humans the most successfully, and it is highly transmissible, and to date has caused over 100,000 cases, and it will likely cause many, many more. The clinical illness that it causes is essentially a viral pneumonia or a respiratory tract infection. About 80% of people who have this infection have relatively mild respiratory symptoms, but more severe symptoms include things like fever and dry cough, occasionally fever and productive cough, headache, myalgias, and typically about 15 to 20% of people will actually require hospitalization and have more severe illness generally for respiratory compromise or complications of viral pneumonia. Typically, the deterioration actually occurs not immediately in the illness, but usually about a week or so into the illness. So people are sick for a week with fever, with dry cough, and then after a week deteriorate and require hospitalization. That's actually one of the distinguishing features between this coronavirus and influenza, which tends to have a more sudden, more explosive presentation, at least initially. So about 80% of cases are mild, roughly 15 to 20%, maybe 25% are more severe and require hospitalization. Within the percentage of patients who end up hospitalized, about 20% end up requiring intensive care unit support with mechanical ventilation to really support their breathing. And the etiology of the respiratory failure is probably the viral pneumonia itself or a complication called ARDS, acute respiratory distress syndrome, which is kind of an inflammatory reaction to the viral pathogen. And folks who end up requiring mechanical ventilation and intubation have the highest mortality rate. About 50% of people will not survive that experience. It seems that the risk factors for severe illness are what Dr. Udell mentioned before. It's older people, people over the age of 60, and people with underlying cardiovascular morbidities like underlying heart disease, underlying lung disease, underlying cancers, et cetera. Those are the folks that are at the highest risk of severe complications in this infection. We know from the series of patients that have been studied in China and evolving series from in Singapore and other countries that have a considerable number of cases, that people 80 and over have the highest risk of severe disease. And in the China experience, about 15% of people over the age of 80 who had this infection actually died from it. It's the highest case fatality proportion. For reasons we don't fully understand, the virus doesn't seem to affect children that much, at least in the first 72,000 cases that occurred in China. Fewer than 2% were in kids, and none of those children were hospitalized or required respiratory support. So the complications of this infection really tend to occur in older people and in people with underlying disease. So the incubation period, which is to say the time between its exposure and the onset of symptoms, is generally around 5 days for this infection. It can be as short as 2 days, and it can be as long as 14 days, but the typical period is around 5 days. And it's an infection that is spread through the transmission of respiratory droplets, which means that people who have the infection and who are coughing and who are sneezing basically expel virus-laden respiratory droplets, and it's through the direct contact with those droplets that others get sick, which is why close contact is something that can be avoided and potentially can prevent infections. We don't believe at the moment that these droplets actually remain airborne. And that's an important distinction when it comes to healthcare environments and transmission potential. It appears that this is a droplet-mediated infection, meaning that it's transmitted through virus-laden large droplets, over 6-8 microns in size, that tend not to remain suspended in air, but basically drop to the floor or contaminate people within a 3 to 6 foot radius, or contaminate surfaces like handrails or doorknobs or countertops. But probably they don't remain airborne. And that's a very important distinction because in airborne contagious diseases, we have the problem of airborne droplets, very small microdroplets basically remaining suspended in the air. And that requires special air handling in hospitalization situations. It also requires special respiratory protection for healthcare workers who are taking care of patients like that. It's conceivable that in some hospitalized situations, small aerosols can occur in this infection, but probably the lion's share of cases that are transmitted in the community are really transmitted through direct contact with droplets. By the way, just some examples of airborne contagious diseases are things like measles and tuberculosis, which are actually much more contagious than this coronavirus infection. So it's a droplet-mediated infection, and again, it's through direct contact with people who are sneezing and coughing and through contamination of surfaces and then touching those surfaces that people actually become infected. The diagnosis is made through direct detection of viral RNA in respiratory specimens, and we are using at the moment PCR-based technology to identify virus in basically oropharyngeal or nasopharyngeal swabs. This is a test that the technology is relatively available, but the specific reagents and primers in this country have taken some time to become widely available. I have a feeling we'll talk about that throughout the course of the panel. But that is the diagnostic test at the moment. Just in the last month or so, there have been serologic assays that have become available. They are used in part for diagnosis, but probably more for things like serosurveys to get a sense of what percentage of a population has been exposed, and those will be very, very important later on to help us figure out how many people were truly asymptomatically infected versus symptomatically infected, et cetera. So right now, the diagnostic test of choice is really this PCR-based test, which in most situations is not a point-of-care test. It's generally done in our country right now at a state public health laboratory or really in the last week, it's now being performed at some commercial labs like Quest and LabCorp, but because it's not really performed at a point of care situation the way that like a rapid strep screen might be performed at a point of care, there'll be at least a 24-hour, if not longer, lag time between the time of specimen collection and the diagnosis being made. I'm just going to say a few words about treatment and about prevention, and then I'm going to hand over the microphone. At the moment, there are no proven therapies for SARS-CoV-2 infection. There are a number of clinical trials looking at a nucleotide analog named remdesivir. There are some other studies looking at immune sera, but for the most part, treatment is supportive, meaning that people who have respiratory distress need to end up requiring oxygen supplementation, requiring mechanical ventilation or other respiratory support, sometimes intravenous fluids, et cetera, but there is no direct antiviral medication or intervention that we can use, and no pharmacologic intervention that we can actually employ to change the course of infection. It's unfortunately has to run its course. And that's, of course, quite a challenge. There are clinical trials happening now within the context of this emergency response, and I believe that the drug remdesivir was available through compassionate use, but I believe Gilead is trying to funnel all of this medication into clinical trials so that we learn something about its use during this emergency. And finally, with respect to prevention, in infectious diseases, we like to have vaccines to give people to prevent infection, and if we can't get a vaccine, we'll settle for a medication that we can use either pre or post exposure to prevent transmission, and sadly, we have none of those available to us in this infectious disease. So we rely on what we call non-pharmaceutical interventions. That's a term you've probably read about in the news a fair amount, NPIs. And those can be as simple as individual things that we can do, like washing our hands frequently, observing good respiratory hygiene, covering coughs, not shaking hands, etc. But it also means things like staying home when you're sick, isolating sick people so that they can't spread infection to others, and also identifying their contacts and then quarantining or confining their contacts for a period of 14 days, the maximum incubation period, to make sure that they don't develop symptoms and spread it to other people. And that's sort of the mainstay of infection prevention in this disease, and layered on top of that is what we call social distancing, as Dr. Udell said, and that's a much more broader concept where it's about limiting large gatherings, encouraging people to telecommute and not work in shared workplaces, doing things to basically prevent human contact, like canceling parades, canceling events of over 5,000 people, et cetera. And those kinds of things have worked extremely well in the countries that have had the unfortunate experience of being the first countries to actually deal with this. And we're starting to see really dramatic improvement. I think Dr. Levasseur will talk about this in places like China and Singapore and Korea, where the case counts are going down because of the really rigorous application of these non-pharmaceutical interventions. Should I take questions, or?
I think we should go through and then do questions
Okay,
at the end.
sounds good.
Mike?
Thanks.
I'm going to sit because being tall is hard. Hi, everyone. I'm Dr. Michael Levasseur. I'm visiting assistant professor of epidemiology and biostatistics here at Drexel. I'm also an alum. Finished my doctorate here in 2016. It's a pleasure to be here to talk about something that I'm incredibly passionate about, diseases, which is why I got my PhD exploring them. And I just want to start off talking about some of the numbers you may have heard, because math is hard. And I think math is hard for a lot of people. So there are two big numbers that I know have been floating around the media for the past 2 months. I've been asked numerous times by reporters about them, and I want to clarify some of the calculations behind them. The first that I want to talk about is the basic reproductive rate, also known as R naught. It is something very useful to us in public health to sort of understand and contextualize the transmission of a disease in the context of other diseases, or in ways that we can develop interventions. And there's also a fancy calculation that you can do to turn that value into understanding what % of the population we need to vaccinate to develop herd immunity. It's, I think, just the inverse of the R naught value is the % of people that you need to vaccinate. It's not difficult math, but it's still math, and math is hard. So for the calculation of R naught takes into consideration the number of contacts an individual has on a given day. It takes into account the per contact probability of transmission of the disease, and it takes into account the duration of infectiousness, 3-parameter CPD. And we can intervene on each of those different aspects of disease. We can shorten the course of a disease by providing medications, or reduce the amount of time that people are sick and in front of other people and getting them sick by having people stay at home when they're ill. We can reduce the per contact probability of transmission by washing your hands for 20 seconds and singing a Britney Spears song, if that's what you're into. All of these measures that we're talking about are all in effort to reduce this transmission probability. And so we have a number of estimates of R0 for coronavirus, and they're all wrong, because all numbers that we work with are inherently wrong, because all models are wrong, and that's totally fine. We just hope that we can have really good approximations of what's happening in reality. And so there have been at least 4 different methodologies used by a number of research groups trying to estimate what this R0 value is for this coronavirus. And the median value, these aren't weighted, but it looks like it's about a 2.3. I've got to look at my notes here. About a 2.3. So each individual will go on to infect, it's 2.8. Based on the type of calculations used. The 2.3 number actually is from a data-driven analysis exploring R0, looking at the individuals on the Diamond Princess cruise that was quarantined off of the coast of Japan. So 2.3 I think is a pretty good number because it's data-driven. I'm a data scientist, I prefer data. The other ones are sort of based on simulation models where we theorize what's happening in the world. But in reality, we don't know what's actually happening because we're not out there doing tests on random people in the population to see what the prevalence is yet. I think there's going to be a point in time when we do that, but we haven't done that yet. So as of right now, the R0 value looks to be around 2.3. It's definitely a little bit different depending on the context that you're in. There are cultural aspects that go into it. Obviously, some people have more social contacts than others. So there's, some individual differences. This is a number that's really helpful for public health. Probably not so much for individuals, but it's a number that is being reported on in the media. The second number that I want to talk about is the CFR, the case fatality rate. Sometimes the news talks about the death rate or the mortality rate. They're talking about the case fatality rate. Mortality rate is an entirely different thing. Mortality rate is you take the number of people who have died, you divide it by the total population. That's the mortality rate. The case fatality rate is the number of people who have died divided by the number of cases that we have. And so the case fatality rate, I think it was last week the World Health Organization announced that it was 3.4%. 3.4% of people who were getting this infection were dying, and that was a big news story, and this made things a whole lot scarier. Well, the problem is that we're pretty good at identifying people who have died from this. These are the more severe cases, so they're more likely to go to the hospital, they're more likely to get tested for this infection. But the number of cases, that's a bigger question mark. You heard Esther mention that about 80% of the population has a very mild course of the disease. So with a mild course of the disease, you're probably not going to go to the doctor. You're just going to stay home and watch something fun on Netflix or Hulu or whatever your preferred streaming channel is. And so you don't wind up becoming a part of the denominator. So with both this basic reproductive rate number and the case fatality rate numbers that we're looking at, instead of saying 3.4% of the population is going to die when they get infected with this virus, I want you to think at most. The most that will die is this number, because it really is an upper limit. The cases that we know of, we know is an underestimation. As you increase a denominator, the outcome winds up decreasing. So whether it's 0.7 or if it's 2.2, no one really knows. And I think that's important because different countries appear to have different case fatality rates. If you look at South Korea, for example, there have been 54 South Koreans who have died from this virus, and 7,513 cases. Their case fatality ratio is 0.7. It's much lower than that 3.4% globally. There were 4,088 deaths as of this morning globally, and 116,000 cases. That's a case fatality ratio of 3.5. In the United States, we have seen 27 people die as of, I think, 11 o'clock this morning, and there were 761 cases. Obviously, these are being updated almost to the minute. But that leads to a case fatality rate of 3.5 in the United States. But we also know that we are way undercounting the number of cases in the United States, largely because we don't have enough test kits to go out and make sure that, and see if people have this infection. So that's been a problem, and we'll get a bigger picture in the coming weeks. So I think it's important to keep that in mind. But when it comes to the case fatality ratio, when we're talking about populations most at risk, we have those who are above the age of 80 have between a 14% and a 21.9% case fatality ratio. That population is the most at risk of dying when infected with this disease. Those who are between 18 and 40 years old have about a 0.2% probability of dying, according to these case fatality ratio estimates. It's lowest among those who are under the age of 18 with about 0.2%, and there have been no deaths among those under the age of 9, according to data from the Chinese study. Males seem to have a higher case fatality rate than females, whether that's related to healthcare seeking behaviors or if it's some kind of biological pathway, but males have a 2.8% case fatality ratio compared to females, which is 1.7. Those with cardiovascular disease appear to have a 10% case fatality ratio, whereas those with diabetes have 7.3%, chronic respiratory diseases are 6.3%, and hypertension is 6%. So when we say that people who have chronic diseases are at an increased risk of severe illness or death, it's these groups that we're talking about. Finally, I want to bring up a couple of populations that are particularly of interest based on the questions that I've got. The first question, one of the first questions that I got when I started looking into this virus was, what about pregnant women? What's the effect? It appears they looked at a small study of 9 pregnant women who were infected with this virus, and they found no evidence of mother-to-child transmission and few complications at birth. However, 2 of the babies studied did go on to become infected later on by the mother. And then I mentioned earlier that there were 9 infants in China who were infected with SARS-2 between December of 2019 and February of 2020. That number is probably likely because the children, these infants had a very mild course of disease. So again, if you don't have a serious course of disease, you're not going to go to the doctor to get tested. So it's probably larger than 9, but I think the news here is that infants and mothers don't seem to be at particular risk when it comes to this disease. It's very early on in the epidemic, but these are the numbers. The other population I want to talk about in particular are healthcare workers who are at substantial risk, largely because they're in the hospital or in the healthcare setting caring for people who are ill. And in China, there were 3,387 infected healthcare workers, including 22 deaths as of the end of February. Obviously, the majority of those cases were in Wuhan, which was hardest hit by this epidemic. Initially, the healthcare workers didn't use adequate personal protective equipment. These are the gloves that you might wear. These are the face masks, and and so we wanted to. We didn't want to do anything. The long-time exposure to large numbers of infected patients with long shifts and few breaks, this led to a lot of mistakes among healthcare workers. They became more at risk of becoming infected. There was also a shortage of personal protective equipment, which they've started to work with, and they felt that there was a lack of proper infection control training in these populations. So when we're talking about the healthcare workers here in America, we want to make sure that that they have the proper training, access to the PPE that they need, and that we have a large enough supply of workers in our workforce who are healthy enough to come to work. So when we talk about washing your hands, you might not be in one of the groups that are high at risk of dying from this disease or even having serious complications. But at the end of the day, we're all in this together. We are a community in this room. We're a community in this city, and we need to work together to protect those who are most at risk. That's all I've got to say.
Good afternoon. My name is Jim Bueller. I'm a clinical professor in the Department of Health Management and Policy and the interim chair of that department at the Dornsife School of Public Health. Most of my career has been in government public health service. The biggest chunk of that time has been at the Federal Centers for Disease Control and Prevention in Atlanta. I've also worked for a number of years with the State Health Department in Georgia, and for the last year and a half of our previous mayor's administration, I had the honor and pleasure to serve as the health commissioner for the city of Philadelphia, where we had two public health crises ourselves. The Ebola situation that, although we had no cases of Ebola in Philadelphia, we have a large West African community and many people traveling back and forth between Philadelphia and West Africa during that time. And the Pope decided to visit, and that occupied a tremendous amount of time to anticipate and be ready for any public health problems that might have emerged. We were lucky none did. But today I'm going to talk a little bit about what are health departments and what is CDC and what do they do? Professor Udell talked about a public health response, and so I want to provide some background to our discussion on what that is. And I'll cover 4 topics. What do health departments do? How do state and local health departments work together? And how do they interact with the Centers for Disease Control and Prevention, or CDC, which is a federal government agency? What are some of the specific things that health departments do to prepare for and respond to public health emergencies? And how does this relate to coronavirus? So in explaining what public health is, I like to make an analogy to the relationship between you and your doctor. You go to your doctor and your doctor monitors your health over time. Your doctor provides services like immunizations and advice that aim to protect you from getting sick and help you stay well. If you do get sick, your doctor tries to identify the cause, provide treatment and other recommendations to help you get better and to prevent you from getting sick again. Well, that's pretty much what public health does, except in public health, our patient is a population. So, for example, for the Philadelphia Department of Health, their population is everybody that lives in Philadelphia and everybody that visits Philadelphia. But that analogy, like any analogy, is imperfect. And one area where it breaks down is that when we serve populations, not everybody in our population is at equal risk of disease. And it's important that we think about not only the individuals that compose the populations that we serve, but also the forces that act on different groups within that population in ways that can affect their health either positively or negatively. And a typical mission statement for a state or local health department is something like to protect and promote the health of the people in our city or our state or whatever the jurisdiction is. So we're hearing a lot about CDC in the news. What's its job? CDC is our nation's leading public health agency. But in the United States, it's the states that have primary responsibility for public health, not the federal government and not federal agencies like CDC. Many states delegate that authority to localities. So, for example, in Pennsylvania, the state of Pennsylvania delegates public health authority to the Philadelphia Department of Public Health. But CDC plays a tremendously important role. CDC has a deep bench of experts in many different fields, people with substantial experience in addressing a broad spectrum of public health problems, like coronaviruses and other pathogens that have emerged in recent years. CDC provides guidance and assistance to states. CDC, along with other federal agencies, but CDC is the biggest contributor, are the source for over half of all funds that state and local health departments in this country spend. And that varies in different parts of the health department. So, for example, in the Division of Disease Control here in Philadelphia's health department, about 85% of its funding, the money that goes for things like basic infectious disease prevention and control capacities, immunizations, bioterrorism, and emergency public health response, that money is coming from CDC. CDC works with states to coordinate efforts and set standards. So, for example, how do we define a case of coronavirus? Well, the CDC and the states work together to create standardized definitions so that when we're counting cases of a coronavirus infection in one state, they're comparable to what's being counted in the next. And CDC collects data from states to develop a national picture. So these data that we hear about how many cases in the United States, that's filtering up to CDC from states. In turn, states call on CDC for help when they face complicated problems. States and local health departments take materials and guidance from CDC and adapt it for their own use. So for example, much of the information that you see coming out from health departments, that's based on information that they're getting from CDC. But CDC as a federal agency lacks the authority to act directly within states or localities. And more importantly, it's the state and local health departments that understand the situations in their areas. They know the players, they know the healthcare providers, they know the communities. And then, in turn, states delegate much of that authority to localities. So the relationship between CDC and states is a prime example of the federalism at play in our government. But counties aren't independent actors. States aren't independent actors. We have to work together because viruses really don't care about where the county line or the state line is. So what do health departments do? Well, one of the most important things that health departments do is they track the health of their patients. They track trends in a variety of different diseases and risks to health in the populations they serve, and they do that in a variety of ways. For infectious diseases, health departments are very dependent on information that's collected when people seek health care, when doctors or others make diagnoses. That information is then reported to public health departments. And when our patient in public health gets sick, in other words, when there's an outbreak of disease, then investigations are conducted to identify the source, to identify or inform interventions to see how well we're doing in bringing it under control to track the course of an outbreak. For large-scale emergencies or high-profile events like coronavirus, we draw on our experience in previous situations. So all of those diseases, those other coronaviruses that we've heard about, SARS, MERS, Ebola, et cetera, we learn from our experience in dealing with those in the past. But we also learn from what we do every day, the annual flu season, the ordinary outbreaks, what we do to protect people during mass gatherings. And I've often said that the best predictor of a health department's ability to respond to a crisis is how well it does its job every day. We pull out our emergency plans and our reports and lessons learned from exercises and prior events. That includes our pandemic and influenza plans. And even though influenza is a very different disease from coronavirus, the planning and the consideration, the scenario playing, the planning assumptions are not entirely different. So for example, a common planning assumption is that when we do get a vaccine or when we do get treatments, there's likely not going to be enough of it right away. So who gets it first? How do we prioritize that use? Oftentimes we think about whether it's the healthcare providers, the first responders, those responsible for critical infrastructures, public safety to have priority, analogous to what you hear every time you get on an airplane and they tell you to put your mask on first before helping your neighbor. You've got to be healthy in order to take care of the people who depend on you to be healthy. Health departments convene meetings with key stakeholders like hospitals that participate in coordinated response structures and supplement their tracking systems. With coronavirus, you've heard that our ability to track the extent of it has been hampered by delays in access to test kits. That's changing. But the three most important things for public health in a crisis are communication, communication, and communication with other public health agencies, with the healthcare providers in their community, with the public. And you see that in the materials that are online for the local health department, the state, and the CDC, and all of those are linked on Drexel's coronavirus page. The recommendations that health departments make are going to evolve as the situation evolves. So until this afternoon, the city wasn't recommending any canceling of large events. Now we've heard that Commissioner Farley has said we should back away from events of more than 5,000. You can bet that for that patient who's been diagnosed in Philadelphia, that the health department is out interviewing that person, interviewing his or her contacts to learn about where he or she may have been infected and what actions need to be taken to protect those that may have been exposed to that person. Again, a key point is the recommendations are going to change as the situation changes, as the information changes, as the needs for response change. And with that, I hope I've set the stage for continue our conversation about that public health response to coronavirus.
Hello, everyone. My name is Professor Amen. I'm the Director of Global Health in the Dornsife School of Public Health and a clinical professor in the Community Health and Prevention Department. My training is in molecular epidemiology, and after I finished my PhD, I went to the CDC and was part of the Epidemic Intelligence Service, which is kind of known as the disease detectives that mobilizes in response to disease outbreaks, and investigates the causes of it. And it was fun work. You get energized by trying to understand and how to solve a puzzle. And outbreaks are always a puzzle when they start out. But one of the things that I learned kind of being there was also just how epidemiology sometimes can be too narrow in its focus. And it's kind of like the joke of someone looking for their car keys under a lamppost, and someone comes by and asks them if they can help, and where did they lose their keys? And they said, oh, I lost them over there, but the light's better over here. And that's kind of sometimes what you're doing. You're kind of grappling in the dark. You're getting data where you can, the cases that are in the hospital, but not the cases that you can't detect because they're asymptomatic. And through that process, I also became much more interested in sort of how we use limited evidence and translate it into health policy. And so I want to set the stage a little bit and talk about the coronavirus globally, but also relate that to the ways in which different countries have responded in positive and negative ways. So just to give you an overview, as of today, there are 118,100 cases of coronavirus globally. There's over cases that have been reported in over 100 countries. Not all of those are locally transmitting, but imported countries as well. More than 3,800 people have died. The greatest number of cases are in China, Italy, Iran, and South Korea. And transitioning from just the numbers to the response and to what happens is outbreaks inspire a bit of fear and panic. And often what comes with fear and panic is xenophobia, that foreigners are bringing a disease into our community. Governments have fear of controlling the narrative, and sometimes that results in denial and cover-up. You also find censorship of press, panic, and one of the ways in which governments respond is sort of symbolic political crackdowns or enforcements or quarantine. And quarantine is not always an effective approach. If you look at the origins of the epidemic in Wuhan, which imposed a quarantine first on the city of Wuhan, a city of 11 million people. And the day before the quarantine was announced, 5 million people left the city. So you have two problems there. One is you're tracking the number of cases in Wuhan and seeing this large, increasing exponential number of cases, and then it tapers off. And is that tapering off because you have half the population that you used to have? And you attribute that tapering off to the success of your measure of quarantine, totally falsely. The other problem is your quarantine announcement has just done the opposite of what you intended to do, which is allow people to get out of the city and spread the disease to places that may not yet have it. And the same thing has been seen in Italy. When Italy announced the regional quarantine in northern Italy, people left the region in droves. They quarantined the region, but they didn't stop planes from leaving and they didn't stop trains from leaving. And anyone who could afford to, who had another house or had family outside of the quarantine zone, had an incentive to get out. And that's a historic phenomenon as well that's long occurred. So there's also an inequalities that occurs around disease outbreaks of who can afford to be quarantined, who can afford to get out of quarantine, who can afford to get food while they're in quarantine. I worked a bit on policy responses in the SARS outbreak in China, as well as the H1N1 outbreak and the Ebola outbreaks in 2014 in West Africa. And you saw that frequently, that there were vastly different responses on an individual level depending upon people's resources. So I'm bringing up China in part because there's been some people, including WHO, that have praised the Chinese response for getting serious, getting quick, getting harsh. But I think the jury is still a little bit out on that. China isn't a country with a free press. It's not a country with free civil society. It's not a country with independent legal system. And stories are still emerging about what the effects of the quarantine actually have been. There are cases that have been reported of children who died because they weren't able to access health care because of the lockdown, because of the quarantine. There are many cases that look kind of scary online. There have been pictures posted of people's doors being nailed shut. Who's providing food for people who have disabilities who aren't able to get to the stores? Who's providing food for people that are in quarantine for 14 days? There's a lot of aspects that need to go into thinking through how to impose a quarantine, and quarantines are often imposed in a rush without having fully set up social support systems for the communities. One of the things that I've been starting to talk to is with some of my neighbors, who in the neighborhood may be afraid to go out, even with just the news that we have now of a potential case. Are there ways that we can reach out to them and facilitate and make sure that they're getting some kind of social support? How do you start that conversation? What kind of context do people have? Is it through faith-based organizations? Is it through community organizations? Is it neighbors thinking of these things? Another thing that I think is important to keep in mind is that the extreme cases of crackdowns get a lot of attention. But what doesn't get attention are things that haven't happened, right? The explosive outbreaks that didn't occur. So you see in Taiwan, for example, they haven't had the experience of China. Taiwan is 80 miles off the coast of China. It has 23 million citizens, of which 850,000 reside in and 400,000 work in China, along with nearly 3 million annual visitors from the mainland. Yet Taiwan didn't put in place a quarantine. They put in place a very aggressive system of contact tracing, of screening people, including visitors, and they have 47 cases to date, compared to 80,000 in China. So it's worth looking for examples like that, Hong Kong as well. And I think it's also important, beyond just the epidemiologic arguments, to talk about principles and human rights arguments. And the principles and human rights law around quarantine and the restriction of liberty requires that you take a gradualist approach, that you use the least restrictive means feasible, that you implement more restrictive approaches as necessary. But quarantine isn't really intended to be a measure of first resort, but a measure of last resort. You need to meet requirements of legality, evidence-based necessity, and proportionality. So it's not appropriate to quarantine with the announcement that there's 2 cases in a neighborhood, for example. Voluntary measures, social distancing, calibrated responses are also more effective than heavy-handed ones because they ensure that there's trust. And one of the problems in China was censorship, lack of trust. For governments to be trusted and for people to follow the guidelines, there needs to be a sense of open transparency, a sense of looking out for people. In the Ebola outbreaks in West Africa in 2014, healthcare providers, government officials were targeted and in some cases killed because of fear and myths that the disease was being spread intentionally, and also because of a history of corruption and a history of distrust in the government. And I think that establishing and maintaining trust in a time of crisis where people are afraid and where there's a potential for panic is critical. So the other point that I want to make is just that we need to really think again and again about who's most vulnerable to this situation. And it is, in terms of age, older people, but in terms of the populations, it's the people who may not come forward, whether that's undocumented migrants in our community, whether that's immigrants in detention centers, whether that's other populations that have a history of fear of discrimination in healthcare settings. We need to think about how to reach them. We need to think about the gender aspects of telling people they are in quarantine, and how does that affect women differently than men? How does closing schools affect parents, and who's going to care for parents? When we talk about when we talk about pandemic preparedness, we have to think beyond just, are the local health departments adequately resourced? Are the hospitals ready? Are there diagnostic tests? But we need to think about, are there sick days that are paid for as a right, as part of ensuring that social distancing can work? What are the aspects that go towards community resiliency as a way to think about, are we ready for a pandemic, not just this time, but next time? Because as soon as this pandemic ebbs and gets back to normal, we should already be thinking about what we need to do to prepare for the next one. So I'll stop there and we can have questions. Thank you very much.
So I want to thank our 4 panelists for the amazing information they shared. Before I ask someone else to come up and join for Q&A, if that's okay, I just want to say a couple things. We had originally envisioned this event about 7 or 8 weeks ago as a way to get undergraduates on campus interested in public health. The epidemic then seemed contained, and we were all thinking of it as something that was far away and would not necessarily affect us in certainly the way that it seems like it's about to. So clearly we had to rethink what we were doing. It was going to be a small event in a classroom, and now we have all of you here because of what's going on, which speaks to a few things. One, the fast-paced nature of public health, the way things can change very rapidly, and 2, the importance of getting out public health information as widely as possible to the community. So there are a lot of people here today. There are people watching on a live stream, and this will be uploaded and available for future use for informational purposes. So just remember, public health, it's not always like this, where it's crazy and we're reacting to a global event, but stuff like this happens a lot, and it keeps some of us, it's not really the work that keeps me up at night. I'm not a pandemic specialist, but for many people on the panel it is. So these are events that unfortunately we've seen events like this in our lifetime, the HIV/AIDS crisis and other pandemics, and we need to keep learning from this history, from both the past and the present, so that we are prepared to move forward and do a better job this time and the next time. So before I get to Q&A, I want to ask Annette Molyneux from Student Life to come up and join the panel, if that's okay.
Well, actually, I'm here with Dr. Jana Cruz.
Okay.
Dr. Cruz is the medical director of the Student Health Center, and if it's okay, we can field questions from here. If you have specific questions about what's going on at Drexel.
You guys are welcome to come up and join us up here. Okay. All right, so Dr. Jana Cruz. So let's give her a warm welcome. And I'm actually, we asked for questions in advance when you were registering. So I'm actually, Dr. Cruz, if it's okay, I want to ask you a couple of questions to get things rolling. I'm going to put you right on the spot. And the first question is, what are the measures Drexel is taking currently to prevent the spread of the virus on campus?
Yeah, so that's a multi-layered kind of question, right? So I'm just mic.
Yeah, I think you need one.
Okay, so that's a multi-layered
come up here if you
question.
That way you can
Or-
stand.
Thank you. Now I could stand. So there are several fronts that we try to engage in to limit the spread of any disease. So today it is coronavirus. A couple, just last semester was mumps. So engaging our students and trying to educate them, that's the first layer, right? You are all probably the most important defense to any viral illness, meaning engaging in hand washing, engaging in all of these good hygienic practices, right? The second, we do have implemented protocols for taking in, concerns from students, concerns from faculty members. We also have different protocols if we do have a student that ends up identifying as high risk for coronavirus in this instance, right? How we can best support students. And this is where Annette Molyneux and I really work hand in hand. So I kind of take care of the medical piece, being, boots on the ground, right? And then engaging with advisors or student life to make sure that these students, as they are recovering from such an illness, that we, take care of all the things that they need for support, meaning food, housing, engaging with faculty members, and then also protecting the rest of the university. So.
And then to add to that, understand too that we are part of a larger emergency preparedness team where everyone on campus who needs to play a part in decision-making around protecting our students, making appropriate decisions as we go along regarding response to the coronavirus, and any other infectious instance that we have to manage. People are talking all the time. The communication, as you said, communication is so important. We are in constant communication with each other and heeding to the advice from our experts. We have extremely talented people here. We are so lucky to have all of you here on campus in order to make the appropriate decisions in the appropriate amount of time to protect the community.
Great. One more question that I know many of us have been thinking about, especially as we watch other universities prepare for moving online. What kind of discussions are going on at the university now on that front, and when can we expect more communication?
So Provost Jensen has instructed all of the deans to work with faculty to be able to use Blackboard to put as many courses as they can online in the best way that they can, so that if the university closes, there won't be any interruption in academic progress. So those are ongoing conversations. Again, being responsive to the changing and information changes, data comes in every minute. I mean, the situation is changing constantly. So our provost, our president, the academic deans are all working in concert in order to be able to manage a situation should the university close.
Great, thank you.
Yeah.
I want to ask one more question from this list, and then I'll open it up to the audience, and it's a practical question about masks. We've seen in a lot of images, particularly from Wuhan, people on the streets in masks, and the question is, if the virus may be able to go through masks, why are they recommended for healthcare professionals, and how would you explain this to the general public who's questioning these different recommendations in different places? Whoever,
I'll weigh in. I'm sure.
One of the physicians.
I'm sure other people have opinions. So you see a lot of people walking around with surgical masks, and I think the one point to make that's key is that surgical masks are designed for source reduction. They're really effective when sick people wear them who are coughing and sneezing to prevent them from expelling respiratory particles out into the air. That's the most important and use of the surgical mask that you see, that the kind of mask you're seeing on the street and what you sometimes see in healthcare facilities. Sometimes healthcare workers will wear surgical masks when they're taking care of people for droplet precautions, but it's really most critical for them for people who are contagious and coughing to wear those masks. You're also reading about N95 masks, which are sort of a higher level of respirator that people wear in healthcare settings where there is the potential for airborne transmission of infectious particles. So these are those smaller particles that remain airborne and that can be inhaled. The N95 mask is a sort of half-faced, usually disposable respirator that healthcare workers wear that requires fit testing to make sure that you wear it correctly. And they're not supposed to be reused, although they're often reused in situations like this where they're in short supply because of high use. And the challenge, I think, with all of these masks, the surgical mask and even the N95 mask when it's worn in healthcare settings, is that they get contaminated. And they can provide a false sense of security, particularly in healthcare settings, but even in the community. If you wear them all the time and people are sneezing and coughing onto your mask, and then you go like this to take your mask off, you're contaminating your hand and then potentially something else. And so they're fraught with problems. They make people feel secure because they feel like they might be warding off or preventing or filtering, infectious particles from being inhaled. But that's probably not what's happening. They're really, the main use for them, the most effective use is to put them on people who are sick to prevent the rest of us from getting sick. Does that answer your question?
It does. So I'm going to open questions to the audience. Do we have a mic we do? Okay. So we have a question right down in front. Hang on, wait for the mic, please.
I keep hearing that it's not a pandemic. Is it?
Yes.
It's a pandemic.
It's a pandemic. According to the World Health Organization, I believe the definition of a pandemic is community transmission in two separate countries that are in different parts of the World Health Organization's special areas, of which there are 6. And since we have it in Europe and we have it in Asia, that fits the criteria for me. But it's a sort of an administrative difference between an epidemic and a pandemic. And I don't think it means anything to me personally that it's a pandemic versus an epidemic, but
It's a political decision about not wanting to spread fear, and there's also pandemic bonds that have been issued sometimes that pay off if there is a pandemic, so there's some consequences to calling it a pandemic. But for all intents and purposes, it is a pandemic.
Other questions? Right down here. Oh, we got 2 mics. Thank you.
Hi, I'm Neil Goldstein from the Epi and Biostat department here at Drexel. My question, well, the $1 million question is, what's the future hold for this outbreak? And we can turn to history to kind of inform that discussion, right? We can look at historic outbreaks, see how they've played over time, how various interventions have helped. And the comparison I'm seeing a lot now, and my question for the panel, is the flu outbreak, the flu pandemic from 1918, the most appropriate comparison here? Because health and health systems have changed quite a bit. We're not in a global war. And I think that comparison actually induces a lot of anxiety because of the extraordinary amount of mortality and morbidity that resulted from that. So is there a more appropriate comparison that we can make, or is this truly an unprecedented outbreak right now?
There's probably bits and pieces of different situations that have relevance here, but there's nothing that's exactly like this. And as you mentioned, the world today is a very different place than it was in 1918, and the 1918 flu virus had a very, very different pattern of morbidity and mortality from coronavirus. So we learn from previous events, but there's no clear roadmap. And there's a lot of uncertainty, as Professor Amon has mentioned, about really what is the effect of some of these measures, like social distancing, like canceling large events. I mean, the explosion of influenza in Philadelphia in 19, shortly after a big parade, is pretty convincing that parade was an amplifier for the epidemic. But again, the guidelines, is not a strong clear base of good, solid evidence. We have to use our best judgment, taking bits and pieces from what we know from previous situations, as well as input from people like mathematical modelers who can make predictions and help inform interventions.
So you're going to hear the term flatten the curve a lot when you talk about what do we have to expect. And so, in infectious disease epidemiology, we talk about epidemic curves where we basically plot numbers of cases over time. And there's a period of time where the epidemic is increasing, and then it peaks, and then it gets better, and we see fewer cases and it comes down. And the goal for our therapeutic or non-pharmaceutical interventions is to diminish the amplitude of that curve. And we call that sort of flattening the curve. And that means cases will probably curve further out in time, but there might be fewer cases over time. We diminish the wave or the curve of infections. In the setting of pandemic influenza planning, the hope is that if you can diminish the amplitude of the first wave, you buy yourself time to generate vaccines that could potentially prevent or attenuate the second wave. In this situation, I think no one's expecting there to be a vaccine in 6 months. It'll be more like maybe 12 or 18 months if we're lucky. But the goal of flattening the curve here is to relieve the burden on healthcare facilities, particularly when it comes to intensive care unit beds and monitored situations, and just trying to reduce the burden on health service delivery. The question is, how do you do that? How do we, flatten the curve, or how do we mitigate some of the impact? And I think we're all we're learning as we go here. There's pretty good evidence from China that the shoe leather epidemiology work of case identification, contact tracing, contact quarantine seems to work well. I think, as Joe pointed out, the other layer of just more blanket social distancing and quarantining of 10 and 15 and 30 million people, it's not as clear what that contributed to. But there's no question that some of that work in terms of just identifying cases, isolating them so they can spread to fewer people, and identifying their contacts, particularly because we see so many mildly infected people who might be transmissible. That kind of work is key to mitigating and so-called flattening the curve so that we at least relieve the burden on the healthcare system and prevent infections.
Great. More questions? There's a question in the back.
Hello, my name is Adam, and I'm a graduate student in the Material Science Department here at Drexel, and I have a two-part question. So I realize that this is speculation, but can you speak to, from both a school policy standpoint and a public health standpoint, what would be the criterion to make the decision to cancel classes or, I guess, move them online? And then from the perspective of a graduate student, that does my research in a lab and I cannot work from home, what would be the criterion to that the university shuts down and close and lock its doors?
Turn that over to you guys.
Okay, I'll start. Well, this is a complicated question, of course, and it takes a lot of thought and many people working on trying to find a solution to that or an answer to that question. But the university doesn't work in a vacuum. So I think depending upon what's going on in the city, what's going on with our neighboring universities, the information and advice that we get from our experts will drive, that thought process and ultimately end up in a result where if it's advisable to close the university for any length of time, and this would be a question I would have to the team here, then that would happen if it's advisable to do that, given, as I said, we don't live in a vacuum here. We have the city, we have all of the key personnel on campus, and we look at our sister universities in the city to try to make that decision.
Jim?
If I can just add to that briefly, CDC's issued interim guidelines for institutes of higher education, universities, and when they talk about closing a university, they don't mean closing the university. They mean suspending the meeting of classes. But people that are in administrative positions or not in classroom settings would presumably continue to come to work. And I wouldn't want to speak specifically to a recommendation about laboratories, but in a laboratory, you're not in a room with a whole bunch of people, and so the value of canceling classes is not going to extend to people like you that are in a laboratory. These would be the types of conversations we would have within this committee that we're talking about.
Joe?
And if I can just add, the situation analysis has to include the fact that, some people don't, if you close the school, some students don't have homes to go to necessarily, right? They've already bought their meal plan for the year. They may not have a lot of money to pay for food for the next several months. What is interesting to me is that schools are doing a lot of different things right now. I was just reading before coming to this panel about a school that decided to have online classes for 2 weeks after spring break, presumably to then reassess and decide, have things gotten a lot worse or not? And I think kind of understanding how much flexibility to build into programs where you are reassessing and where you're able to then either intensify or back off is an important kind of thing to keep in mind. Sometimes it's not practical to do that, but where it is, it can be very useful and also mitigate some of the negative consequences of the steps that have to be taken.
And there's no formula. There's no number that says if you cross this threshold, then it's time. The other thing is, as Joe suggests, is if you do take that step, when do you deactivate that step and go back to business as usual? Again, there's no clear time. CDC strongly recommends that as universities think about this, that they do that in collaboration with the local health department, so that ideally schools are acting in a consistent way. But we need to think about why are we doing that? What's the objective of that? What are we hoping to achieve? Is that the best way to achieve our objective? And these are not going to be easy decisions, but the decisions that we'll have to struggle with.
Thank you. More questions? Yes, right here.
Hi, I'm Chuck Haas, professor of environmental engineering, and my expertise is actually microbial risk assessment. And I'm going to toss something to you, Esther. I understand the dominant route is certainly direct contact with large emitted material. I don't like the word either droplet or aerosol. But I don't think based on that you can ignore other routes. And, I don't think we know what happened in the Diamond Princess yet enough to rule out what are typically called aerosols as routes of exposure in a very crowded situation like that. So, reaction.
Yeah, that's fair. I mean, we were just talking about this. How do you know for sure? And the WHO just came out with this joint report from China, with China stating they're confident that the primary route of transmission was droplet and not aerosol. And I'm guessing they made that judgment based on looking at the numbers of cases and patterns of transmission and comparing it to known airborne pathogens like measles and varicella or tuberculosis. So you're quite right. I think there are scenarios, and as I said in my remarks, I think certainly in certain scenarios, aerosols are likely generated. Somebody's intubated, somebody's getting a nebulizer treatment. There are scenarios where aerosols very likely are generated, and there's a percentage of people who could be infected that way. It's impossible to know in most situations. But I think, most coronaviruses, the human coronaviruses, tend to be droplet, the large droplet transmitted in terms of the common cold viruses. Is this one different? It's hard to know. It'll be hard to know. But I think, to me, it made some sense to think, just looking at the numbers of cases and the clusters around households, and that likely it requires relatively proximal direct contact for transmission. That said, our Centers for Disease Control and Prevention suggest that in healthcare settings, healthcare workers observe airborne precautions. And in the clinic system where I work, we're bending over backwards now to fit test, hundreds of healthcare workers so that we can, take care of folks with coronavirus, SARS-CoV-2 infection. Do we need them? Will there be some relaxation of that recommendation based on types of healthcare setting? I would imagine that will likely happen at some point in outpatient settings where less acutely people are taken care of. Maybe you don't need N95s, but at the moment CDC's not relaxed that, at least in healthcare settings. So that's what we're observing. It's erring on the side of caution.
And there have been some studies looking at the persistence of SARS virus in rooms of patients back in 2003 when that epidemic was occurring, and it doesn't seem like it lasted in the air for very long at all, although it was detected in patient rooms. So it's a little, it's very hard to do that sort of study, but.
Well, I would push back on that. I'm not sure what papers you're referring to, but some do show some persistence, certainly for hours in the air.
The ones I've read haven't showed that it lasts very long whatsoever, that it sort of declines after a period of time. But we can exchange information and talk about those papers.
So we've got a few minutes left, and I want to get a couple more questions. So there's a question in the middle here and a question on the end over here. So if we can get those two, actually 1, 2, and 3, if that's okay.
Hi, my name is Carol. I'm a first-year epidemiology PhD student. I just have a question regarding the capacity of testing at Drexel. So see a student or a faculty member is showing some symptoms, see fever, coughing. Are they advised to stay home and being self-tested, or going to first student going to student health center to be tested, or do we have the kit?
Yeah, so I could kind of answer that since that's been my my work over the last week or so. So to limit exposure, we're asking people to call into the health center for obvious reasons, right? Those phone calls get filtered to me, and then I interview patients over the phone. And then consort with public health to see if the student needs testing. So that's kind of how we've done it. We haven't had many cases. We haven't had any cases that test positive, but you still go through cases that you go through your protocol. So with that said, if the public health department does recommend samples, we are doing those samples in public health in selected people. We do have a room set up, for isolation. We do have a protocol set up with the providers where they don on the appropriate PPE per CDC recommendations. So your second part of the question, I know in the news it was announced that anyone that wanted to get tested for coronavirus could get tested for coronavirus. That wasn't what the public health departments recommended. There are some laboratories that are developing the coronavirus test commercially, so LabCorp being one of them, and I'm in discussions with LabCorp on how we could bring that to student health to be available for mainly our students to be tested. Right now, the turnaround time for coronavirus testing through public health is a little bit complicated, right? So you want one test and then make sure that it's a positive test, right? So there's an initial test that is done. If that initial test is positive, then that sample is sent to CDC or a different lab to get processed and ensure that that is a confirmatory test. For a lot of the commercial labs, right now we're looking at a 3 to 4 day turnaround time through the commercial labs, and if it tests positive, they still have to go send that sample to the CDC to confirm that it was positive. So a lot of that is in the works. Right now, for high-risk students, there is testing available. We work really in collaboration with the Philadelphia Public Health Department to make sure that individuals that are high risk, right, per their guidelines, are tested and are tested in a timely fashion.
Thank you.
Sure.
So there was one question right in front of the last question, and then we'll go over to the other end and wrap it up.
Hi, Kevin, third year mechanical engineering student. I wanted to ask the panel on advice, suggestions, examples that differentiate just being cautious, safe, like social distancing, versus acts that display xenophobia?
So I guess I could start to tackle that so I feel like that's mainly my script in student health, right? So a lot of college students recognizing you are my patient population, right? Go to parties, like to share drinks. Don't do that. Try your best not to do that. Wash your hands. That is the best thing that you can do. You know, if you see that someone is sick, offer them a tissue. You know, if you yourself are sick, cough into a tissue or blow your nose into a tissue, discard it, wash your hands. I mean, that is the bread and butter. I have these discussions with college students all the time because I know, I mean, I'm probably dating myself, you know, there are drinking games that people engage in. Yes, like, please be cautious with, I know it sounds silly, but if you're sharing cups with others, if you're sharing vape with others, which our students do, right? These are the sort of acts that will spread any disease. You know, any viral illnesses, or most of the, you know, like cold-like viral illnesses, flu-like viral illnesses. So those are the sorts of activities that I would say, really rethink that. And then in terms of social distancing, if someone, you know, can kind of chime in, a lot of that is avoiding kind of large groups, you know, where if someone is sick, you could potentially get exposed to them. The big thing that I was seeing in the literature is with casual contact, meaning in a room full, we believe that the risk for you getting coronavirus is very low as opposed to living with someone that has it. So, you know, continue to practice good hygiene. That is going to be the bread and butter and the way we prevent, you know, disease spread.
Go ahead.
I'd like to add to that. I have a son who's a junior here at Drexel, and he told me an anecdote of seeing a group of students waiting to get on an elevator, and one student stepping back and not getting on the elevator based on that student's assessment of the ethnicity or the race of the kids that were getting on. That my heart to hear that students would act like that. You can't tell if someone's at risk of exposing you to coronavirus by looking at them. You can't tell that by the color of their skin or their race or anything like that. And so we really have a tremendous responsibility to stand up for the type of behavior that we think is appropriate as fellow human beings. And if people do act like that, then the person who might think that they're sick is maybe reluctant to go get health care. So, I mean, you're raising a really, really important point. We need to be appropriately cautious, but we can't give in to that type of fear of people who are different from us.
And the university takes a really clear stand on that. If anyone is subject to any sort of bias incident, then please let the university know that. There's our Office of Equality and Diversity that would respond immediately to that. And we want to be careful that none of our students are treated in any way differentially because of whatever factor.
Those are really important answers. And I just want to add in terms of the social distancing aspect, during the last 90 minutes, both Joe Biden and Bernie Sanders canceled their campaign rallies in Ohio tonight as part of this movement towards social distancing. So these are the kinds of things that will have an impact on our lives in some way, but aren't discriminatory and singling out individuals and groups. So thank you. We have time for one more question in the corner.
Hello, I'm Gonzalo. I'm an undergrad student here at Drexel. And I know the situation is far from over, but as a global community, is this outbreak teaching us lessons on our resiliency levels, on how to tackle big emergency situations like these ones, and if there are any holes or any failures that public health systems are showing here and across the border?
Joe, you want to jump on that one? Thank you for your question.
I think always there are lessons that come out of this. And sometimes those lessons are heated and sometimes they're not. In the case of the SARS outbreak, there were huge lessons learned by China, for example, that led to, I think, a quicker response with the current outbreak, and certainly also true in Taiwan. I think that there are other things that are sort of so much deeper problems that even drawing lessons from this outbreak are going to be hard to break, such as the example of xenophobia and racism and treatment of people who are different, and of the need to address, reduce our prison populations, which are incredibly vulnerable right now, to really look socially at our healthcare coverage to make sure that people aren't afraid that they're going to get charged for the coronavirus test, for example. So I think it's going to be a mixed bag, like it usually is, where we're going to come out of this with some stronger lessons, which will help us, but we'll still have many challenges to face.
So, quick closing thoughts from anybody before I close the panel?
If you're sick, stay home. Don't be a hero. That's the take-home message.
Wash your hands.
And don't shake hands and hug right now.
Don't touch your face.
Don't touch your face. Anything else?
Clean your phone. That'll get dirty.
So I think when we kind of, all join in, it's really, this is a collaborative effort, and all of you are part of that, right? So it all starts with, each one of you taking those small steps and really emphasizing hygiene. We all have our sets of responsibilities, right? Student health, my obligations to you, the students, I have to work in partnership with public health, et cetera, but we all have a role to play in this. So, be mindful of others, educate others, and take the time to really practice those good hygiene practices.
And if you have additional questions, you can find all of us on the web at Drexel. Please email us. We're happy to answer questions. There's a lot more work to do. There's both the personal side of this, which we've been talking about, but there's the community side, which we also touched a lot on. At our department meeting today, we were talking about all the questions that aren't being asked right now about prisoners and homeless populations and the most vulnerable among us, who are, as they often do in situations like this, suffer the most deeply. So please be aware of that as we make our way through this. And again, thank you for joining us today, and please don't hesitate to reach out with questions. Thank you for coming. And thank you to our terrific panelists. I'm sorry, I didn't.